Hello, learners, and welcome back. In our lecture today, we're going to continue to focus on trauma-informed care. We're going to be specifically addressing evidence-based treatment, interventions, and supports as it relates to substance use disorders and trauma-informed care. We're going to start by looking at physiological interventions. We all understand the importance of sleep. We know that sleep has a restorative value of physically, mentally, and emotionally filling up our cup. So lack of sleep contributes to lengthening and exacerbating PTSD symptoms, as well as substance use disorders for individuals who have irregular sleep patterns and who have experienced traumatic events. They are more likely to want to use mood-altering chemicals as a maladaptive way of coping. The neuroscience shows that when people are triggered, we need to help them gain a better understanding of relaxation so that they can improve sleep patterns and have a holistic recovery approach. Many clients with PTSD report sleep disturbances, particularly with nightmares related to trauma and with heightened arousal symptoms. These symptoms prohibit the client from falling asleep or staying asleep. This is fairly common for individuals who have an addictive disorder because of the rewiring of the central nervous system and the brain synapses. Individuals have difficulty regulating chemical imbalances that will allow them to sleep restfully. We also see that people then attempt to either pick themselves up, to stay awake, or to potentially use depressants to help them relax and cause them to fall asleep. Awakenings during the middle of the night may interfere with REM sleep, which stands for rapid eye movement, and this is known to many to assist in emotional adapting for a traumatic event. REM sleep occurs at regular intervals throughout the night, providing a person with about 4 to 5 REM cycles in a normal night's sleep. Research has shown that most dreaming typically happens during REM sleep. However, nightmares experienced by clients with PTSD occur during REM and non-REM cycles. This is bringing to our attention that regular sleep patterns and how unrested a survivor of trauma may potentially be, so we need to keep this in mind as we work with them. Nightmares can be a process of healing and bringing fragmented pieces up to the traumatic event and back to the consciousness. So being a strength-based approach, we are going to recognize that healing is happening here, but focus on ways to allow people to relax in order to fall asleep and to stay asleep. Some of the relaxation that we can incorporate include stress inoculation training. This consists of a number of coping skills that will reduce anxiety in our trauma survivors. Things that include stress inoculation may look like relaxation, breath work, biofeedback, physiological interventions, role playing, communication techniques, and interpersonal assertiveness. Some thought stopping and self-regulation techniques can also be a part of stress inoculation. Some of the areas that we're going to focus on as part of relaxation is guided imagery, progressive muscle relaxation, and passive relaxation. Guided imagery can use the senses in a very creative manner, and this can be a way to allow a client to visualize themselves in a place that's safe for them and allows us to explore the safe place with them in terms of our senses. This is a way to show individuals that whatever images they're able to see, whatever visualization does for them, that they do have control over their thoughts and that they do have control over how they feel. And this is the ultimate message with going through guided imagery. We can also allow guided imagery to be very meaningful. We can ask the client to go back to times where they felt most safe. Maybe they were around people and tapping into what it is that they like and how do we bring pieces of that into today and allow people to use that as a self-rescue technique. Progressive muscle relaxation, also known as PMR, is a series of tensing and relaxing various muscle groups. When we engage in progressive muscle relaxation, we ask the client to sit comfortably in their chair. We want to make sure that their feet are flat on the ground, and we want to start by tensing muscles either in the feet or in the head. We may want to be mindful of where the person experienced a trauma and work away from that point first. So if someone experienced a trauma in their lower body, as an example, we may want to start with the head region and work our way down. So we start relaxing the process before we get to those focal points where the trauma occurred. Again, we do not want to re-traumatize the individual. So with the relaxation, we are asking them to feel the tension and the tightness, and then to feel the pressure. We ask them to breathe in and hold that tension for a few moments, and then we're going to breathe out and let go. As we let go through the various different muscle groups of tensing and then relaxing each group. This is going to offer the person a sense of control or mastery over their physiological condition and response, which is sometimes something that people feel that they do not have or did not have in the past, especially during their traumatic event. Passive relaxation seems most appropriate for individuals who may be agitated, maybe they're not quite ready or able to do guided imagery. Maybe it's just too much for them to handle. So passive relaxation allows the individual to shift their energy a little bit differently. This might be reading a book, maybe listening to a particular type of music, finding interests and hobbies that promote a healthy distraction for those individuals. Exercise, we would be remiss if we didn't talk about this. Exercise has been widely known to decrease anxiety and depression. This helps us with endorphin release and causes people to have more feel-good chemicals. So if we can work with individuals to increase their motivation to be able to exercise and explore what this might look like for them, again, this will allow for different sense of self-control. Lastly, here we've got mindfulness and meditation. These can be infused throughout the trauma treatments for drug and alcohol clients as well. And we want to help them self-regulate versus using mood-altering chemicals to feel a certain way. So with stress inoculation, there's a lot of focus on breath work. I'm going to go through 4 different types of breath work with you. These are nice interventions that can be incorporated in the counseling session and skills that people can learn and then eventually take outside the counseling session. We're going to start by looking at diaphragmatic breathing. The steps in order to complete this activity would be asking the client to sit in a comfortable chair. Again, we want them to have their feet on the floor, making sure that they are comfortable and they're feeling safe before we get started with this exercise. We're going to ask them to put one hand on their chest and one hand on their belly. We're going to ask them to notice where they're feeling their breathing without giving them any instructions first. Usually with individuals who are having heightened arousal, anxiety, and stress levels, it's likely that they're going to be breathing from their chest, and normally they're experiencing more shallow breathing. They may also have increased heart rate, and perhaps they're able to feel that too. We're going to ask them to shift that energy in terms of breathing and instruct them to focus on breathing deeply and really shifting the breath and allowing for their diaphragm or the hand that's on their belly to fill up with oxygen. When I do this exercise with kids, I ask them to puff their belly out like a beach ball. I know it sounds silly and ridiculous, but it's a good visualization for someone who's never done diaphragmatic breathing. Then we ask them to exhale slowly through their nose. This is very much a preferred method versus breathing through the mouth. And this technique can be used several times throughout the day as needed. We can start to incorporate in small time intervals. We really want to see this being used in 5 to 10-minute increments. When I teach this exercise to folks, I let them know that once they learn the way that the breathing should feel, they no longer have to have their hand on their chest or their belly if they don't want to, which means that they can use this diaphragmatic breathing maybe when they're sitting in traffic, when they are having a difficult conversation. So again, they can use this technique in various different situations where they need it, and yet no one needs to know that they are doing a breathing exercise. Visualization is able to enhance diaphragmatic breathing. Clients are able to choose the image that's helpful for them. For instance, a client might inhale and they may visualize white puffy clouds up in the sky. We might want to explore with them what those clouds symbolize, how they were feeling in the body, and what sensations came about when they were breathing and how they saw those clouds. As they exhale, we could help them visualize maybe releasing toxins out of their body and what that means for them and their system and how it feels to be able to let go. Moving on to balloon breathing, we're going to ask people to stand upright with their arms by their sides, relaxed. We're going to ask them to breathe in deeply through their nose and feel their diaphragm. To hold that breath for about 5 seconds while tensing all the muscles in their body, particularly their neck and shoulders and upper arms. And we want to see the tension, and we want to see the body hold that tension and constriction. And then we're going to ask the individual to become aware of what that tension feels like in their body. We want to explore questions that will provide answers to help them about where they are most likely to hold their stress and becoming aware of that feeling of where the most tension lies. During grief and trauma, some individuals are not aware of how much tension their body is actually holding. So this is a very purposeful exercise by tensing all the muscles and bringing awareness, and then helping to explore this where we might be holding it most can be a real realization for clients. When we ask people to hold their breath and breathe in through the nose after holding the breath for about 5 seconds and then tensing their muscles, we're going to ask them to release their air suddenly through their mouth. This resembles kind of popping a balloon, so it's a nice metaphor for individuals, even in terms of visualization. Lastly, for timed breathing, this is an excellent technique that will allow the individual to slow down the breathing process. The individual can then experience decreased arousal symptoms. So here we're going to ask the client to close their eyes if this is something that feels safe for them and something that they may be willing to engage in. Again, we do not want to re-traumatize the individual, so maybe at first closing their eyes does not feel safe, and maybe this is a goal that we can eventually work towards in treatment. So we ask them to close their eyes if they feel comfortable. We're going to give them a moment to take in where they're at, to feel grounded and to stay grounded. We're going to ask the client to breathe normally, and we're going to ask them to inhale and exhale for a period of 1 minute. We, as the counselor, want to count how many breaths are happening during that time. We have learned that if a client breathes 18 to 22 times a minute, this is indicative of high levels of anxiety. Normally, a person who is in a relatively relaxed state should breathe 8 to 12 times per minute. So here is a goal to set for treatment. If the individual has intense anxiety level and they have shallow breathing, maybe they're breathing, like we said, 18 to 20 times per minute, we want to do some scaling with them to determine how to relax and to decrease the breathing. If we're staying at 20 breaths per minute, what type of relaxation is needed to help us move down to even 19 breaths per minute? What would it look like if we were down to 12 times a minute? So this technique is excellent for physiological control and mastery. The client can use these techniques themselves whenever it is needed, and this is pretty realistic to incorporate almost anywhere in a subtle way to allow people more tools to self-rescue. Next, we're going to talk about psychopharmacology. This is a major intervention when working with individuals who have substance use disorders, as well as survivors of trauma. Psychopharmacology may be used to help people develop the ability to cope differently. It may be more of a maintenance medication. Everybody's going to be unique and different. I have often been asked how long an individual should be on a particular type of medication, especially medication-assisted treatment. And ultimately, the rule of thumb in our society today is if it's not broke, don't try and fix it. If people are doing well on a medication, We don't want to risk re-traumatizing them by titrating them off the medication. It is a different story if someone wants to get off the medication, then that's a very different conversation to have. But if someone is doing well on a medication, they're not really interested in coming off of it, then that is a perfectly fine way to stay and to allow them to continue to use the psychopharmacology as a tool in their recovery and mental health treatment process. We really want to have conversations through these stages of change and looking at recovery and relapse, asking individuals what it would be like if they were to decrease the medication. Have you given any thought to wanting to do that? How do you want to do that? How do we work with individuals, meeting them where they are, and ensure that their safety is first and foremost? Ultimately, psychopharmacology can reduce the number of symptoms. It can reduce the frequency or severity of intrusive symptoms, reduce the tendency to interpret incoming stimuli as perceived trauma or reoccurrences of a particular traumatic event. It can help with reduction of hyperarousal, also reducing avoidance behavior, impulsive behavior, aggression behavior, depressed mood, numbing, or dissociative symptoms. When we are talking about treatment for PTSD, the first line of treatment is always going to be a trauma-informed therapy, but sometimes people are so activated that they need psychopharmacology or medications to be able to help get them to a state where they can engage in therapy. And that's why we're having this conversation here. There are many theories as to how psychopharmacology works, and when it comes to PTSD, there are many different medications that we could talk about. Here today, we're going to talk about specifically the neurotransmitter serotonin. There are theories out there about the deficiency of neurotransmitter serotonin and how when we use something such as an SSRI, which stands for selective serotonin reuptake inhibitor, that we are able to allow for more serotonin to be in the synapse and in the brain. And with this, it helps individuals improve their mood. There are different types of SSRIs. SSRIs are an entire family of drugs, and there are several that are approved specifically for PTSD, which are sertraline and paroxetine. And you can see in parentheses, those are their brand names. So sertraline's brand name is Zoloft. You've probably heard of that. Paroxetine's brand name is Paxil. These are particularly FDA approved for PTSD. However, when it comes to psychopharmacology, oftentimes prescribers are using lots of different medications that may or may be not FDA approved for that. And when they prescribe something that is not FDA approved, we call that off-label use. There is a good amount of off-label prescribing when it comes to various different conditions, especially post-traumatic stress disorder. So let's talk a little bit more about what the research shows us. Zoloft is more effective for women than it is for men. Here we're recognizing gender, culture, and other aspects of ethnicity and health and well-being in terms of medication and how it will metabolize for one individual versus the next. Again, it's going to be very important for us to remember that everyone's physiological mechanisms are going to be somewhat different. Even though this is what the research is telling us, we may have someone who is a poor metabolizer and their metabolism for particular psychotropic drugs is just very slow. On the other hand, we may have someone who is an ultra rapid metabolizer and the medication is moved through the body very, very quickly. So again, we want to take everything with a grain of salt and remember that there's going to be individual differences when we're working with folks. If we look here, fluvoxamine, Luvox, is used off label. So is citalopram, Celexa, as well as fluoxetine. Fluoxetine's brand name is Prozac, and there's research to show that it is more effective in civilian-related PTSD compared to combat-related PTSD. We do know much more research in the field is needed to better understand how medications are working and really getting to the individual basis of what's going on to work best for the type of person and particular genders. maybe particular PTSD experiences, and seeing effectiveness of SSRIs and how they can be most helpful. Some other things that we didn't talk about here on this slide, folks who experience PTSD nightmares, there are medications out there, particularly Prazosin. Its brand name is Minipress. It is supposed to help with PTSD nightmares. However, again, the first line of treatment is going to be imagery rehearsal therapy. Imagery rehearsal therapy is going to help the individual work on the nightmare during the daytime. And in a nutshell, what this treatment does is that we have, and with imagery rehearsal therapy, the person who has nightmares, and this treatment is going to be best for, is the person who has nightmares over and over and over again, but it's the same nightmare. And I've done a lot of this work with my veterans. So what we do is together we work on what is that nightmare that keeps happening over and over and over again. So we have the client tell it to you. Then we work on what is a way in which we can change this dream to something that is more neutral or more positive, and ask the person to kind of suspend reality. They can come up with whatever it is that they need to come up with to change this nightmare into a more positive or neutral dream. Then once we come up with this together, we ask the client if they feel comfortable with kind of what the end result is of how they've changed the dream. They have it written down, and then their homework is to go home and, in a relaxed state, normally in the daytime, to practice this new dream and to visualize it over and over again. And with enough practice in the daytime, eventually, that whenever it comes to sleep, we have practiced this new dream enough that the new dream kind of takes over at night and displaces the nightmare. And this will take time, and you will have several sessions with a client doing this type of imagery rehearsal therapy work. However, I've seen it be incredibly effective with people who continue to have the same nightmare over and over again. So I encourage you to look into this treatment. It is very easy to do, and you don't have to have any particular type of training. The protocol for the imagery rehearsal therapy technique can be easily found online. So I encourage you to look into this. On the other hand, I had mentioned Prazosin, brand name Minipress. That is going to be useful for people who have nightmares. However, if they ever choose to stop that medication, they don't want to use it anymore for whatever reason, those nightmares will come back. So whenever we're using imagery rehearsal therapy, we are making changes at a much deeper level so that eventually the nightmare will change into a normal dream. Hopefully the person can continue to sleep throughout the night and not be disturbed because of the changes that we've made in a relaxed state during the daytime. Whereas Prazosin is another tool in our toolbox. However, the nightmares will come back whenever we stop Prazosin. So something to think about. There are also other classes of medication that are used more off-label for folks who have PTSD, and these would be things like clonidine or guanfacine, and these are going to help the person who has a very high level of physiological arousal. It's going to help them calm down. So again, a lot of the symptoms that we have with PTSD are associated with hyperarousal and just being in a very physiologically activated state. So with medications like clonidine and guanfacine, these are going to help the individual come back closer to what their baseline is so that they can be a little bit more relaxed and feel like they have a little bit more control over themselves. Those medications can be dosed once a day, or they can be dosed twice a day. So one pill during the daytime, one pill before bed, which can also be helpful for them to get into a little bit more of a relaxed state before falling asleep. So these are just lots of various different options for you. I know that this may be a little bit too much into the weeds. I am a prescriber, so I wanted to make sure that you have a little bit more information about these medications, especially because you may be seeing things that aren't FDA approved, or you may be seeing things that aren't on this particular slide here, and you may have questions. So I just wanted to give you a little bit more information here as to why you may be seeing some medications being prescribed to folks that maybe seem a little confusing. When we start to combine psychopharmacology, PTSD, and addiction, we need to look at how to break the stigma around medication-assisted treatments and psychopharmacology. There's a great wave of individuals and groups of individuals that will say you can't be clean if you're on medications. You can't be clean if you're on Suboxone. You can't be clean if you're on an anti-anxiety medication. We have to challenge these thoughts. This is often a part of a person's experience in a recovery process, so what is working for them is going to be unique for them. We have to help them have a voice in what recovery looks like for them to really shatter the stigma that's associated with psychopharmacology and various diagnoses. With that being said, we need to be mindful of interactions of particular drugs. If you have an individual who has alcohol use disorder or abusing alcohol, as an example, they have PTSD, they may be prescribed an anti-anxiety medication such as a benzodiazepine, and there are two that are listed here, alprazolam, brand name Xanax, and then clonazepam, brand name Klonopin. These could be potentially prescribed to someone who has PTSD, who has very high activation levels. However, this class of medications, benzodiazepine, is typically not prescribed for folks who have some type of substance use disorder history because benzodiazepines can be easily abused. Also, benzodiazepines and alcohol both have the same depressant effect on the brain and the central nervous system, and this can be a very lethal combination. So we need to be talking to people about the risks and benefits of treatments and the risks of interacting medications. So people just need to be educated about what it is that they're taking, and hopefully their prescriber can do that for them, but you can also be part of this conversation. We also want to talk about prescription drug abuse. What are people doing with their leftover prescriptions, especially controlled drugs? Our epidemic with the opioid use disorders has really shed some light on the overprescribing practices in our history. Some people have been prescribed a large amount of controlled substances at a time. They're not taking all of them. They're maybe putting them away in the medicine cabinet, and they may have a loved one or a family member or someone in the home who has experienced a substance use disorder, and therefore that medication may just be sitting there and could be acting as a trigger for them. They may be seeking that type of medication, so we want to make sure that we're talking about drug take-back centers and what to do with prescriptions that they're not using and how to ensure that they are safe for individuals. There are a number of evidence-based treatment interventions when we're talking about PTSD. And if you remember on a few slides back, I mentioned that the first-line treatment for PTSD is going to be some of these evidence-based treatments, particularly for trauma. Again, some folks may be far too activated in order to take advantage of any of these therapeutic modalities. However, that's where the pharmacology comes in, so that maybe we can help individuals calm down, come to a little bit more of a baseline before we engage in any of these trauma-based interventions. I've done a lot of these various different modalities. My favorite is EMDR and brain spotting. If you'd like a full lecture on these, let me know. I'm happy to do that for you. But we're just going to talk very briefly about them today, just so you kind of have an idea of what's going on. First and foremost, one of the most well-known interventions is EMDR. That stands for eye movement desensitization and reprocessing. EMDR is very trendy right now. A lot of people don't know that it was actually developed in the late 1980s by Francine Shapiro. It was actually her dissertation, which is just kind of wild to imagine. But this is an integrated model that draws from behavioral, cognitive, psychodynamic, body-based systems in therapy. So there's a lot of different things going on with EMDR, but it provides a profound and stable treatment effects in a very short amount of time. It really truly does. Bilateral stimulation, a very fancy word. All it means is that what we think we know is that the left side of the brain controls the right side of the body. the right side of the brain controls the left side of the body in very simplistic terms. If we move both sides of the body at the same time, we're activating both hemispheres of the brain so that they can talk to each other. As we do this, we are trying to reprocess the trauma. The name is eye movement desensitization and reprocessing. However, Francine Shapiro mentioned that she wished that she didn't call it that because you don't actually have to use eye movements for the bilateral stimulation. There's lots of different ways that you can do it. When I do EMDR, I do not use eye movements. Instead, I have tappers, which they are kind of the shape of a little pebble. They go in the client's hands, one in the left hand, one in the right hand, and they buzz, and I can change the speed, the intensity of the buzzing, and they move left and right, back and forth, and that is another form of bilateral stimulation. EMDR is a very well-researched treatment model. It's capable of addressing multiple instances of a trauma simultaneously, so we see a lot of really excellent effects. EMDR is one of my hardest hitting tools. In my clinical toolbox, I use it all the time, and I encourage you to look into it if this is something that's of interest to you. This model can be safe and it is very brief. Normally people feel better in 1 to 3 sessions, and it just has a lot of effectiveness. Next up is cognitive behavioral therapy, CBT. This is one of our most famous therapeutic modalities in general. It can be encouraged for the treatment of trauma to help the individual to walk through what is real versus what is a perceived threat, some negative core beliefs, ego defense mechanisms, developing improved coping skills to engage in effective new forms of thinking, and ultimately achieving behavior modification and the ability to self-regulate. In vivo exposure is another evidence-based treatment for the intervention of PTSD. In vivo exposure refers to the direct confrontation of a feared object or activity or situation by the client. So here we may be looking at flooding. An example of in vivo exposure intervention might be a woman who suffers from PTSD. Maybe she fears the particular location where she was assaulted. Perhaps we would assist her with going to the location and directly confronting those fears as long as it feels safe to do so. Again, we don't want to re-traumatize people. We want to help them get stabilized and have the ability to self-rescue. And these other interventions may come into play if the person is prepared and willing to do so. Another more gentle way of doing in vivo exposure is for someone to create a fear hierarchy. And this would be whatever their feared situation object is, that they would create a hierarchy starting from 0, something that doesn't cause any distress at all the way up into 100. And so we're coming up with various different feared items, feared situations, feared thoughts that we are starting very low, things that cause very little fear. Then we're moving up to things that cause a mild amount of fear, a medium amount of fear, and then we are trying to work up to the goal of something that causes an extreme amount of fear. So that's another way to do in vivo exposure that is more gentle for folks, and you're likely to keep them in treatment much longer if you're going to do a graded experience such as that versus throwing them into the deep end. While that might work for some clients, you may end up having a lot of clients drop out of treatment with that type of flooding situation. So everybody's going to be different in what it is that they can and can't handle, what it is that makes them feel safe. So sometimes it's just enough to have a conversation with folks, explain what some of these treatment modalities might look like, and give them the power. Ask them what it is that they would like to do in their treatment. Another example of in vivo exposure could be a person with social anxiety disorder who fears public speaking. They, for homework, may be asked to confront these fears by giving a speech. Maybe this is in terms of the 12 steps, that they're leading a 12-step meeting, that they're starting to confront those fears, and they're allowing people to self-regulate and integrate those experiences to see that they can, in fact, master their health and wellness. Again, if this feels too overwhelming for the person, maybe they just attend a 12-step meeting. Then to move up higher in their fear hierarchy, maybe they start to think about what it would be like for them to speak up in one of these meetings. Then maybe we ask them for homework just to write down what they would say. Then maybe the next step in the hierarchy is to be at home alone and to read their notes out loud like they were giving a speech. Maybe the next step is to go in front of the mirror and to rehearse the speech. Then maybe they rehearse the speech to one person or two people who they feel very safe with. And so, as you can see, we are working to create not too much anxiety in the individual so we can get them to their goal. And we are just slowly ramping up the anxiety in a way that is hopefully very manageable for the person. Okay, let's move on to cognitive processing therapy. There are four main parts of cognitive processing therapy. It is very, very scripted. It is very manualized. We're going to be looking to learn about PTSD symptoms as they are unique to that individual. We're going to help them become aware of thoughts and feelings that they are experiencing, have specific learned skills that are going to promote changes in belief patterns. This is very manualized, as I mentioned, and it will take, I think, 16 sessions. Oftentimes it can take much more than that, just because you may find yourself spending a lot of time on particular modules like power and control, things like that. So making sure that you have enough time to work with that individual and to truly give each of the modules justice and to spend more time where you need to for that particular person. We're going to be looking at specific distortions of thinking. The impact statement is a huge part of cognitive processing therapy. That's often one of the very first things that we do with folks is we have them write in very, very detailed language what they saw, heard, felt during the traumatic event. And then we have them read that in session. So it can be intense for some folks. And then we're going to help them enhance their coping skills. I'm also going to mention here trauma-focused cognitive behavioral therapy. There are third-party payers that are willing to provide enhanced reimbursement rates for people who are certified as trauma-focused cognitive behavioral therapist or any trauma certification for that matter. I'm starting to see it more frequently. If there are specialization certifications, people are offering enhanced reimbursement rates because of the specialty trauma that's being offered to individuals. So I encourage you to talk to your supervisor, your provider, your agency, your third-party payer, and see if these specialty types of training can enhance the treatment services that you are providing, as well as reimbursement rates. And as far as stress inoculation training, we discussed that a little bit a few slides ago. All right, so I want to take us through a specific intervention that we can incorporate throughout the trauma treatment. Remember, we need to be cautious so as not to re-traumatize our clients. These techniques might not always be appropriate, and I do want to share them with you so that you have it in your back pocket. And for individuals who are stable, self-rescue, but has work to do, these might be some nice interventions to incorporate. So this is a form of narrative exposure therapy, and we're going to walk through about 5 narrative models, and this is a scaffolding process for individuals that are in trauma treatment with us. This is going to integrate a number of methods, including trauma-focused CBT, some cognitive processing work, some prolonged exposure. So here we're going to provide the tools for individuals, again, to self-rescue, to self-regulate, and be able to process and integrate the trauma experience. First, we are going to help them create a graphic timeline. In this graphic timeline, we're going to explore the beginning and the end of the traumatic event in our counseling session. We're going to start to explore when they first perceived the threat. What was that like? What was going on? What did they notice? What did they see? What did they feel in their body? What did they hear? What did they potentially feel? When did you first perceive this threat? That's going to be the beginning of the graphic timeline, and that's going to help us integrate trauma treatment into a recovery process. Next, we're going to look at the end of the timeline. When did you first realize you were going to survive? When did you first realize the traumatic event had ended? That this situation was over and something else was coming next? That you knew you needed to focus on getting treatment? That you knew you needed to get medical attention? So how did you first realize that this had ended? Sometimes clients have difficulties finding the endpoint. It's important to know that the parasympathetic nervous system, we've discussed this previously, will cause a person to fall asleep. Remember, this is the reptilian brain, the very, very old part of the brain. And this is all about survival. So eventually, people will sleep. If the person cannot find the endpoint of the traumatic event, sleep often becomes the endpoint of that traumatic event. Next, we're going to ask them to complete the middle part of the graphic timeline as part of their homework. So we have given them the framework of the beginning and the end, and we're asking them to walk away and fill in those middle parts as they see fit. So here's an example of a graphic timeline. When people are filling these middle pieces in and we start to talk about this, we can ask them if they still want to continue. We can ask them about any difficulty in completing this, how they might be able to support themselves and guide themselves through this process. If they're having difficulty, we can also put it in an envelope and hold it for them until they are ready to address it. So there are many opportunities to use very mindful approaches about where the person is in their experience and to allow them to be effective in this process and not to push to re-traumatize them. Here you can see an example of a graphic timeline. When people are filling in these middle pieces, we're starting to talk about the event. We can ask them if they still want to continue, how they're doing, how they're feeling. We can ask them about any difficulty that they have in completing this exercise and ask for ways that we can support them and guide them through this process. If they're having a difficult time, we can always take this graphic timeline, put it in an envelope, and hold it for them until they're ready to address it. So there are opportunities to be mindful about where the person is in their experience and allow this to be an effective process and not to push to re-traumatize them. An example I'm going to use here is the traumatic event of a car accident. The beginning of the traumatic event for this individual was that they saw a vehicle coming. They knew that they were going to be impacted. So we want to know, what did they see? Well, they saw a Jeep coming towards them. That was the beginning of the traumatic event. Then the middle pieces we talked about are the impact, the car starting to flip, the car being upside down. This is approximately the middle point. Then we look at the car as it was upside down. We see people coming to the scene, people wanting to help support this person, help get them out of the car. This client remembers the seatbelts being unbuckled, getting out of the car, EMS arriving, and this is towards the end point of the trauma when EMS has already arrived, they're providing medical care, and the person knows that they're going to be okay because they're getting help and medical attention. So this could be an example of a graphic timeline. Next, we're going to talk about the narrative process. This is a written narrative, and we're going to be taking about 5 minutes to write out the first half of the graphic timeline. So we want this narrative process to exist with the graphic timeline. This helps to integrate the narrative and the sensory memory. This is also an important time to implement relaxation skills, such as the deep breathing techniques that we've already talked about. If we're noticing people are having a difficult time, they're having physiological reactions, including the breathing technique, we can say to the client, "You look like you're starting to tense up. How can I support your relaxation to be able to complete this exercise? Are you willing to complete this exercise? Are you able to do it?" So we are including these relaxation skills. And next, we're going to offer about 5 minutes to write about the second half of the graphic timeline. Again, we want our client to have a relaxed body, and we continue to prompt them to engage in relaxation as we move through. The third part is a pictorial narrative. This is done by asking them to have 6 squares on a piece of paper. And in each of those 6 squares, we are going to draw a picture that tells the story. So with these graphic timelines, we have a great opportunity to narrow that down and to say that we only want to see these 6 most significant things that you remember about the traumatic experience so that it's not very lengthy, that it doesn't feel overwhelming. And in this pictorial narrative, we will remain with 6 pictures. We now have gone from the timeline to the narrative and then into drawing the pictures. So here we see an example of a pictorial narrative. Again, we're only going to be asking the individual to do this for about 10 minutes. We're going to want to ensure that they remain in a relaxed body while we're doing this. And as we did before, we're going to ask them to start with the beginning and the end. They will be drawing those pictures first. Next, we're going to ask them to fill in the middle pieces. We can learn a lot from a person's art and how they're describing the situation, how they're drawing out that situation, what they use to describe, and that it's very much worth processing. And as we go through the continued sensory nonverbals, they're doing the pictorial narrative. We're going to process this experience. As soon as the survivor completes the drawing, we're going to ask permission to talk about this narrative. We want to ask the survivor to use the pictures to tell their story, again with a relaxed body. You have a drawn timeline, you have drawn pictures, you have started to write about these experiences. Now I want you to take all of that and to tell me your story. I want you to be able to use this with a relaxed body, incorporating self-rescue techniques where you need them. We're only going to interrupt the person should they become dysregulated. And if they are becoming dysregulated, we're going to use the interventions that we've been talking about to help decrease arousal symptoms and provide relaxation. Once this is complete, we're going to talk about the event. We are going to thank the survivor for their strength and resiliency it took to walk through this process with us. Again, we're going to allow for about 15 minutes. We do not want this to be overwhelming or ongoing for the individual. Lastly, we're going to be moving into the recursory narrative here. We're going to ask the individual to share their drawing with us. Instead of simply telling us their story, we're going to ask them to tangibly hand it over to us, that pictorial narrative. We are going to take that from them with their permission. We will then tell back the survivor's story, and as accurately as possible, we want to use the same language and inflections that the survivor did. We're going to use their name, third person language. We are going to use gender specific pronouns. We will not embellish or elaborate on the story, but we are simply reflecting back the story as the individual presented it as closely as we possibly can. The important concept here is for us to stay relaxed as well, so we are incorporating our own skills. This, of course, is about the narrative, the sensory memory, the felt memory, to support healing as part of the recovery process. And we want to be able to not only stay relaxed, but to promote self-rescue throughout this entire process. Lastly, we'll be looking to close the session. We will take approximately 5 to 10 minutes to end the session to discuss the survivor's reaction to this process. We will be offering some suggestions. We want to know that what this process was like for individuals, and we want to follow up in the next session. Individuals will often leave the treatment feeling as though they made significant progress, only to have trauma triggers come up maybe 2 to 3 days after the session. So we want to ensure that there's a nice safety net, a safety plan, contingency plan, that we have supports in place, and that we have a realistic plan and realistic resources, and to identify coping strategies that do work for this person. Finally, something that we can include as distraction would be counting backwards as an example. We can tell the person if they are experiencing arousal, they can start with 100 and count back by sevens. And this is going to allow for distraction and decreased arousal symptoms. Overall, there are a lot of techniques that can be used. I encourage you to explore what seems to be a best fit for you. I encourage you to continue to seek training, resources, supervision, specialty trainings to help promote your professional growth and development around these. and maybe consider what might be difficult for you while doing the work with this particular population of trauma survivors or those with substance use addictions, and where you need to focus your own work in order to be well, because we will be walking through the trauma with people and helping them heal. But with that, we know it comes with the risk of vicarious trauma. So we need to engage in self-care for ourselves as well. Again, I thank you for your time here today. I look forward to future lectures together where we can continue to talk about collaboration, advocacy, self-care, and self-identity as a professional.